All right, so what that last talk was about was the nervous system. So we've got our sympathetic nervous system, its receptors, chemo and baroreceptors, and its output, the vasomotor center, innervation of the arterioles and the heart. Okay, other players play a role in the management of blood pressure. One of the things the nervous system cannot do is create or get rid of fluid, right? All it can do is make vessels bigger or smaller, make the heart rate beat faster or slower. It cannot change the amount of circulating blood volume, right? That is going to be the kidney's job, all right? The kidney is the place where plasma volume is maintained. So the nervous system can do moment-to-moment blood pressure control by tweaking the valves, right, and the heart rate. But ultimately, the kidney has to manage the homeostatic fluid balance. And that's really what we're going to be talking about today and tomorrow. So, and I know we haven't talked about the kidney yet. You have in your past, though. To refresh your memory, the kidney is essentially a pressure-based filter, right? You put blood in under pressure, and you have a kind of mesh screen, and that pressure pushes out the waste products, right? And pushes out excess fluid. So that means that there's a relationship between blood pressure and how much urine the kidney makes. More pressure, more urine, right? Because of how it works. If you think about, your water filter at home, the higher you turn on the tap pressure, the faster your water bottle fills up, right? So it's the same kind of thing in the kidney. The higher the pressure, the greater the urine production, and the faster plasma volume decreases. Okay, that's our talk today in a nutshell. So if we look at that in a graph, okay, here's urinary volume output, here's arterial pressure. We can see pretty starkly that as arterial pressure increases, the amount of urine that's produced also increases, okay? So, and that's because the kidney uses blood pressure as its energy source for excretion. We call this phenomena pressure diuresis, all right? That the higher the pressure in the blood is, the more urine the kidney is going to make, all right? Now, this does make sense because fluid ultimately is what creates blood pressure in the first place. In other words, you've got a heart, you've got resistance. The last piece you need to have blood pressure is something to make pressure in, right? That's going to be your plasma volume. So more pressure, more urine, and then that causes the amount of plasma volume to decrease, the pressure decreases, and then we're back to baseline, right? And we're going to do a lot of those homeostasis diagrams as we go in the next week. So water has to follow salt. So high pressures also cause salt excretion. We call that pressure natriuresis or sodium excretion. So increased blood pressure, for whatever reason, causes both things, both natriuresis and diuresis. All right. So let's look at the relationship of plasma volume to urinary output, cardiac output, and blood pressure. All right, so to take out the responses that we've been talking about, the nervous system responses, we have an experimental model here again. The dog has had its sympathetic nervous system disconnected so that we can see the effect of volume without the effect of the nervous system, okay? So we have cardiac output is here, urinary output is here, arterial pressure is here, time is here, okay? So we have time that we have just sort of equilibration or baseline. And then at this point, we're going to give a large amount of blood. So we're going to give a blood transfusion at this point. Now, what do we see? As we add volume to the cardiovascular system without the sympathetic nervous system attached, we see an increase in pressure. Now, if I take you back to the pipes analogy, all right, if I have a system of pipes and it has pressure 10, and I add a bunch of water to the pipes, will the pressure go up or down? It's going to go up. I've put more stuff in the system, right? So we're going to have a higher pressure. That's what we're seeing in the bottom graph. I've added volume to the system. The volume has nowhere to go except to become pressure, so that's what happens. Now, that increase in volume also increases cardiac output. Why? Because if I give you a bunch more volume, I'm going to make your venous return go way up, right? More blood's going to come back to the heart. The heart's going to fill up extra before the next beat, so EDV is going to go up. Now Frank Starling's relationship says that means the heart's going to push out even more blood, okay? ESV is going to be even smaller. So we see an increase in cardiac output with an increase of blood volume. This is one of the reasons we give patients fluid, right? We give them fluid because it makes their cardiac output better. It makes their blood pressure higher, right? It's our primary treatment for shock. All right, now let's look at the middle graph. If pressure goes up and cardiac output goes up, well, because of how the kidneys work, urine output is going to go up because we're putting more pressure into the same kidney, so it's going to create more urine in response to that higher pressure, right? Now, so all the three things go up, but eventually they drop back down to normal. Why? Well, this increase in urine output is eliminating the extra volume that we put in the first place, right? So we gave the patient extra fluid, but then the increased pressure that resulted made them pee that fluid back out until we're back to where we started from. So this is an example of pressure diuresis in real life. If we give volume to a patient, their pressure will go up, but that's also going to increase their urine output. Now, that isn't always the case. If the patient's hugely dehydrated and we give them extra fluid, you're not going to see a big increase in their urine output because they were dry to start with. Do you see? But if I take one of you and give you an extra liter, your blood pressure is going to go up, you're going to pee a whole bunch, and then you're going to come back to baseline, right? The body is self-managing. It's homeostasis. And notice that even without a sympathetic nervous system, we get back to baseline within 60 minutes after the transfusion. Pressure diuresis takes place relatively quickly because it's a physics phenomenon. You know, we don't need to have the nervous system. It's entirely about pipes and tubes and pressure. So we end up with pressure diuresis. Now, another way to look at this is we have our intake-outtake on the y-axis, arterial pressure on the x-axis. Now, I think the intake or output is a little confusing, so let me just tell you or try to describe that. These two, the amount into a patient and the amount coming out of a patient, generally speaking, have to match, right? That's your ins and outs have to match. Now, in clinical life, those of you who've taken care of patients at the bedside, you know that ins and outs don't always match, okay? Some of that is we can't measure all the outputs, and some of that is we have changing status in the patient, okay? But in general, you know, think big picture. The amount in has to equal the amount out, or you're going to keep getting bigger all the time, right? So it has to be approximately the same. That's why they put it on just one axis, all right? So when our intake, I'm just going to talk about intake for right now. When our intake is normal, in other words, 1 times normal is normal, for those of you who are math challenged, right? Oh, come on, that was a little funny. All right, so at normal, we have, so at a normal intake, which would be a normal output, we have a pressure, right? In this case, it's just under 100 millimeters of mercury, and this is probably mean arterial pressure. All right, now, let's say that we increase our intake, we double our intake. All right, so now we're here. Well, if we double our intake, we'll see that our equilibrium point has moved to the right. So if you drink double the water, your blood pressure will tend to go up. Not double, it won't double, this isn't a linear line, right? But we'll go from 100 to say, 120, right, at double. Now if we go down, opposite occurs. So if we cut our intake to half, our blood pressure will tend to fall, right? This is dehydration, technically. When we have, and then at that point, we'll have a lower blood pressure. So this system of how intake or output affects blood pressure is very persistent. In the minutes to hours, it's very persistent, all right? So, we've all had the experience of, you drink a lot of fluid and then it's like a clock starts, right? Because you're going to be, where's the bathroom, and not very long. This explains that, okay? When you increase your intake, you're going to shift your pressure. That's going to increase your urine output until your pressure comes back down again, all right? We call that infinite feedback gain because this system, it will just keep working. If I give somebody 8 times their normal fluid, their blood pressure will increase and their output will approximately be 8 times normal, right? So changes to the intake make for changes to the output and so on. So we call that the kidney volume pressure curve, and they look like this. So you have arterial pressure and input or output volume, in other words. All right, let me hang on what I'm looking at. Okay, so the degree, this curve is one of the determinants of blood pressure, all right? So in the normal case, like in A, if we look at A, the blue line is the normal case. Well, in a patient with hypertension, instead of being on the blue line, they end up being on the red line instead. So, and that's not because of their fluid balance, it's because their arterial pressure set point is different. And we'll come back and talk more about that later on. But what I'm trying to show is that the kidney can move its line. In other words, factors can change which turn the blue line into the red line. In other words, push at a normal intake, our pressure goes up, all right? So like the Renin-Angiotensin-Aldosterone System, for example, does this. It shifts the curve to the right because it causes systemic vasoconstriction, all right? So on the bottom graph in B, this is showing you how a difference in intake will result in an increase in pressure. We kind of already talked about these examples. So if we quadruple your intake, your pressure is going to go up. That increase of pressure will result in quadruple the output, right? And then your pressure will go back down as your plasma volume falls. So these two things, intake and where on the graph the pressure curve is, ultimately determine the pressure of the patient. So in the spring, when we get to understanding hypertension, this will be one of the mechanisms that's talked about, okay? Shifting the renal pressure curve to the right or to the left. Because like what we want our blood pressure medicines to do is shift the renal pressure curve to the left, right? We want to make it so that you have, at normal intake, you have lower blood pressure. Do you see that? So it's a way of looking at blood pressure management. Okay. There. Now, all these things we've been talking about so far are in the acute. In other words, in the minutes to hours. When you shift from hours to days, we see that things are not quite so simple, all right? So to look at our same graph we were just looking at, so intake, output, arterial pressure. If we look at the red line, That's our acute pressure change. In other words, if in the next hour, you double your intake, well, your pressure will go up and so will your urine output. Now, what happens if you did that every day for a week? Does that mean your pressure will just keep going up? And the strange thing is, no, it won't. You'll end up with the chronic blue line. And what's interesting here is we can dramatically change our intake of salt and water and have very little blood pressure change. Now, if you've been sort of putting the pieces together, that should seem kind of strange. Well, how does that happen? Where does the extra volume go if it's not becoming blood pressure, right? So in the chronic case, we get very little blood pressure change for a very big difference in intake. So our output does vary with intake. That you can't change. But the degree to which pressure increases in response to a high intake is a variable. So we have essentially two kinds of people. We have salt-sensitive people and non-salt-sensitive people. And what I mean by salt-sensitive is their blood pressure is salt-sensitive. Okay? So some folks can eat all the salt they want and therefore all the water they want, and their blood pressure never moves. Those are people who are on the blue line, right? Folks who are salt sensitive, they look like the red line all the time. In other words, the more salt and water they take in, the higher their blood pressure is. So in our management of patients with blood pressure, you could, unfortunately this isn't done very often, but you could try to determine if they're a salt-sensitive person or not, because if they are, simply reducing the amount of salt in their diet may very well affect their blood pressure enough. But for those folks who are not salt-sensitive, you have the other systems involved, which we're going to be continuing to talk about, that create that high intake, normal intake are both the same, even though we have a big difference in the amount of plasma volume that's coming in. Another point along those lines is that TPR, total peripheral resistance, does not affect long-term blood pressure. Okay, so remember that total peripheral resistance is the total resistance to blood flow. So the heart's pushing blood out, that blood's flowing through vessels. Well, the vessels are essentially pushing back against the heart. In order to have pressure of any kind, not just in a human being, but pressure of any kind, you have to have a pushing force and a resisting force, right? And pressure is what you measure in between those two things. So total peripheral resistance is the sum of all the resistance of the vessels in the body. Now, the vast majority of total peripheral resistance is occurring at the arterioles, okay? The arterioles are our primary resistance vessels. Now, the reason for that we've already talked about, because essentially the arterioles are the valves controlling blood flow through the capillary beds, right? And if you couple that with the fact that most capillary beds at any given time are closed, right? Because we only have a few busy tissues in any given time, it means that most of the resistance in the body is coming from closed arterioles, all right? Now, we added to that in our nervous system talk that the sympathetic nervous system innervates all arterioles, right? So it means the nervous system can increase or decrease vasoconstriction at the arterioles. Because the arterioles are the primary source of TPR, that gives the sympathetic nervous system control over total peripheral resistance. See that? So it all fits together. Total peripheral resistance, though, is a characteristic that affects blood pressure in the short to medium term, not in the long term. And the reason that we know this is there are a number of diseases, they're listed sideways here, there are a number of diseases that directly affect total peripheral resistance. And what we see in these diseases is regardless of the degree of TPR, which is down here, right? So even as our total peripheral resistance goes up, our arterial pressure across all these diseases stays pretty much the same. So that tells us, now the cardiac output changes, and it has to, all right? This is an equation I haven't introduced yet, but we're going to talk more about it today. All right, blood pressure is cardiac output into or times total peripheral resistance. That's kind of what I was just talking about earlier, right? We have a pushing force, a resisting force, and in between those two, we end up with a pressure, right? So blood pressure is cardiac output times total peripheral resistance. We're going to talk at length about each of those terms here in the next couple of days. But as we see in this, if blood pressure is going to stay the same and total peripheral resistance varies by these different diseases, well, the only way the math makes sense is to have cardiac output change, right? And that's what we see in this graph, that when total peripheral resistance is elevated, like we have in hypothyroidism, right? Then we see a decrease in cardiac output. Or if we have like hyperthyroidism, where total peripheral resistance is 60% of normal, well, then our cardiac output has to be elevated, right? So this relationship is seen in that. Now, the corollary to this, so total peripheral resistance does not affect long-term blood pressure. I'm not saying it doesn't affect blood pressure. Of course it affects blood pressure, right? If cardiac output stays the same and we increase TPR, well, blood pressure is going to go up. What I'm saying is total peripheral resistance doesn't play a major role in long-term blood pressure control. In other words, the degree of TPR that you have is not determining your blood pressure set point. Okay? It's going to vary according to what you're doing, but it's not establishing your blood pressure. Now, the only time that rationalization or idea falls apart is if the kidney vessels are affected. Okay, so if you have increased resistance in the vessels going to the kidney, okay, now you have a different issue because the kidney is the primary site where blood pressure is controlled by using plasma volume. So if we restrict blood flow, in other words, if we increase resistance to the vessels of the kidney responds by trying to elevate blood pressure. Okay, because what it sees is that there isn't enough blood pressure for it to do its job. More on that when we get to the kidney chapter. But so we'll put a pin in that for now about what happens to urine output and all that. We're going to cover that later. Okay, so this is the first of what I call flow diagrams or homeostasis diagrams. We're going to go through a number of these in the next week or so. Because I think number one, it's one of the cornerstones of cardiovascular physiology, and I think it's good practice for you. One of the things you're going to be doing with your patients all the time is looking at how one thing leads to another, which leads to another, and leads to another, right? And then you're going to be looking for ways to affect that chain of events, either through therapies like medicines, pharmacologics, or treatments like surgery. So this is an example of that. Okay, so what are we talking about here? If I add fluid to your system, I will increase your cardiac output and your blood pressure. But I showed that with the dog yesterday, right? So that's us here up here. We have increased extracellular fluid volume. So let's say you came into the ER, you've had vomiting and diarrhea for a day and a half, and they look at you and say, okay, we're going to give you a bag of IV fluids because you look dry, right? Very reasonable thing to have happen. Okay, so here we are. We've increased the extracellular fluid volume. Well, where does that go? Of course, it's going to go into the blood, right? So we're going to increase our blood volume. That's going to increase our filling pressure. In other words, how much of our vascular system is full, so to speak, right? So our filling pressure is going to go up. That's going to increase our venous return, all right? We've talked about that one. More blood going back to the heart, increased venous return, increases cardiac output, right? Because as EDV goes up, ESV goes down, stroke volume goes up, so on. Okay, so that increase in cardiac output, we'll jump down here, is going to cause an increase in blood pressure. Now, in the tissues, in each individual tissue, autoregulation is still at work. So when the cardiac output goes up, all around the body, tissues experience a brief increase in blood flow. Well, when the blood flow goes up, remember vasoconstrictor theory? Well, that's what's happening here, or oxygen demand theory. So the more rapid the blood flow through the tissues, the more those vessels constrict because they don't need that extra blood flow, right? So they're going to constrict down. All those vessels, all those arterioles constricting down increases our total peripheral resistance, right? So we have both increased cardiac output and increased TPR in this case. So of course our blood pressure is going to go up. Well, when our blood pressure goes up, enter pressure diuresis, right? The more pressure you put into the kidney, the more urine the kidney makes, right? So our increase in pressure, because of our increased venous return and our increased total peripheral resistance, leads to an increase in urine output. You pee out the extra fluid, the liter of fluid we just gave you, and now you're back to where you started from. See? So we have created a system that solves the original problem. That's homeostasis, right? You've got to address what the inciting challenge was. In this case, we had too much fluid volume. We answered that with increased urine output, right? Good for us. We maintained homeostasis. So, I think I talked about all these things. Venous return, yep. Frank-Starling relationship. Increase in salt intake has this same effect. Okay, this is a little harder to understand. Easy to understand putting a bunch of fluid in a patient. All right, well now we'll change the scenario. You went off to the movie theater, had the extra giant bucket of popcorn, right? The one you can swim in when you're done with it. All right, so you got lots and lots of extra fluid or extra salt. Well, what comes next? Well, you're going to drink water, right? Because salt makes you thirsty. Why does salt make you thirsty? Because when you add salt without water, you increase the osmolarity. We're very sensitive to osmolarity. So as our osmolarity starts to increase, our brain makes us thirsty. So we reach for fluid. We put the fluid in. So our increase in salt has brought about an increase in fluid, right? Now we're back up at the top. We have increased extracellular fluid volume. Same thing happens. All right, so the kidney can very easily get rid of excess water. It's harder to get rid of excess salt, all right, because the kidney has to move salt. Water always just follows along, but the kidney, it takes energy to move salt. Now, so increasing your salt intake has a bigger effect on your plasma volume than increasing your fluid does. However, a normal healthy kidney can move salt around just fine. It's just going to need more energy to do that with, okay? So this is increasing fluid and or salt because they both result in the same thing, which is increased extracellular fluid volume. Now, there is a case where that does not occur, and that is in a patient who cannot drink on their own, okay? So imagine you have a 2-month-old, and the 2-month-old is getting formula that's been mixed wrong. In other words, there's not enough water for the amount of formula, okay? Usually it's the opposite problem, but we'll call it that. Well, that baby is going to end up having increased osmolarity and probably seizures eventually because they can't just go get water to drink, right? So any patient that can't access water by themselves, increases in salt actually lead to increases in osmolarity. Another patient group is somebody who's, like, let's say they're in the ICU, right? They're paralyzed because they're on the ventilator. Well, you have to manage their osmolarity because they can't, right? A healthy, awake person will manage their osmolarity just fine. Somebody who doesn't have access to water or can't get the water into their mouth to drink, they're going to have increased osmolarity and not increased fluid volume. Okay, so enter our best friend, the Renin-Angiotensin-Aldosterone System, right? Okay, so hopefully you've all heard about this before, but I like to go through it nice and simple to give you a good, solid understanding. So what is it? The Renin-Angiotensin-Aldosterone System, all three of those words are hormones. Okay, they're hormones that are released, and they're released in response to changes in blood pressure and changes in perfusion. Okay, it starts with renin, or renin. Some people call it renin. I learned to call it renin, so you can argue with me later. Renin, secreted by the juxtaglomerular cells. So these are cells in the kidney that are part of the nephron, cells we're going to learn about when we get to the kidney. But they respond to the amount of fluid that is entering the nephron, all right? So what's being measured is essentially urine production. And the juxtaglomerular cells, when urine production falls, they release renin, right? And it's renin then that's going to increase blood pressure. An increase in blood pressure increases urine output. We've already talked about that. So it's renin answers a decrease in urine output with an increase in blood pressure. Okay, so how does that system work? So we get decrease in arterial pressure. That decrease in arterial pressure, I'm going to add a point, leads to a decrease in urine production. Technically, it's a decrease in glomerular filtration rate. Okay, the kidney detects that. The juxtaglomerular cells detect that. And in response to that decrease in GFR, they release renin. Okay, so renin, which is also called angiotensinogen, or rather renin brings about angiotensinogen. Angiotensinogen then gets converted to angiotensin-1, all right? Angiotensin-1 is converted into angiotensin-2. That occurs in the lung. Why in the lung? People are still trying to figure that out. Nobody knows why. I think it happens in the lung because the lung isn't a bad place to put an enzyme because it gets all the circulating blood volume, right? Plus, it may be that this enzyme requires a high level of oxygen, in which case it would make sense to put it in the lung too. That's the highest oxygen tension in the body. But nobody really knows. So angiotensin-1 is converted to 2 by angiotensin converting enzyme, the ACE enzyme of the ACE inhibitor fame, which you're going to learn about later. Very, very perfect, wonderful blood pressure medicine, right? ACE inhibitors are. All right, but in the normal case, angiotensin-1 becomes angiotensin-2 because of that conversion. Now, angiotensin-1 does have some effects in the body, but they're not very potent. Angiotensin-2 is the heavy hitter, okay? It is a powerful vasoconstrictor, angiotensin-2 is. So angiotensin-2 brings about vasoconstriction. It also brings about renal retention of salt and water. That's through the aldosterone system. So angiotensin-2 leads to an increase in aldosterone. I'm pointing to a thing that doesn't exist, but this is where it would be in your notes, right? So angiotensin-2 leads to aldosterone. Aldosterone leads to renal retention of salt and water. So if we increase our plasma volume with aldosterone and we cause major vasoconstriction at the same time, well, we're going to get a big increase in arterial pressure. So the renin-angiotensin-aldosterone system responds to a decrease in arterial pressure with an increase in arterial pressure, right? So it's a homeostatic reflex, all right? Now, the increase in arterial pressure then leads to an increase in glomerular filtration, which turns off the release of renin in the first place, All right, so we're going to look at the RAAS through several lenses. This is the first. We're looking at it through the blood pressure control lens. We're also going to look at it through the control of glomerular filtration lens in our kidney chapters here in a little while. Okay, so know the players. If there's, I have a short list of physiology concepts I absolutely want you to bring into your clinical life. The Renin-Angiotensin-Aldosterone System is one of those, okay, because we're not going to talk about it right now, but blood pressure management, we got a lot of hypertensives out in the world, okay, a lot of people with high blood pressure. Our management of hypertension can be entirely described by the Renin-Angiotensin-Aldosterone System and how we can affect it. So for example, we have medicines that block aldosterone's effect. We have medicines that block the ACE inhibitor effect. We have angiotensin II inhibitors, right? So there are a variety of targets for hypertension control that are present in this system. So what I'm trying to tell you is it's worthwhile to learn it. Okay, so does this system really help? Okay, so if we look at this first curve here, okay, so this is sodium intake or output, right? And this is arterial blood pressure. Okay, so if we increase the amount of angiotensin in the blood, we move from the red curve to the blue curve. All right, so what the heck does that mean? It means it shifts the renal pressure curve to the right, or for the same sodium intake, we get a higher blood pressure when angiotensin II is around. See? So it says the renin-angiotensin system works. Angiotensin II does in fact increase blood pressure for the same amount of sodium that's present. All right? Over here, we can see one of the things that this system is really for. The renin-angiotensin-aldosterone system is to keep you alive after an injury. That's one of its primary roles, right? So, here's a guy playing with a chainsaw again. Terrible accident, doesn't catch the juggling chainsaw. Off comes the arm, okay? So major hemorrhage, right? Without the renin-angiotensin-aldosterone system, if you've lost half a liter of blood to the ground, it means you're going to have a much lower cardiac output, right? So your blood pressure is going to be much lower. And without the RAAS, there's nothing for the body to do. It will do the best that it can, but your blood pressure is just going to stay low. You're going to be in shock. With the renin-angiotensin-aldosterone system, though, all that blood that's been lost lowers your plasma volume, which lowers your blood pressure, which the kidney identifies that, releases renin, we get that whole activity. Angiotensin II causes vasoconstriction, so even though you've lost a half a liter of blood, you still have a blood pressure that's compatible with life, right? So this is a good thing. Now you can't live there forever, but it kept you alive long enough to go get water and replace that fluid that you lost. Right? So the RAAS is, at least in part, a hemorrhage control system. It doesn't stop the bleeding, but it stops the bleeding from killing you. Right? Okay. Well, let's look at salt intake. Right? So over here on the left, so if we increase our salt intake, that's going to mean an increase in extracellular volume, right? Because at least in someone who can drink, they will drink to offset the osmolarity. Their blood pressure is going to go up. That's going to cause a decrease in renin and angiotensin, right? Because we'll have an increase in glomerular filtration, so a decrease in renin, decrease in angiotensin. That's going to cause a decrease in retention of salt and water. Read that as increased urine output and increased salt output in the urine, right? That increase in salt and water output will fix our original problem, which was increased salt intake, and now our blood pressure goes back to normal, okay? So it's sort of the same thing we just looked at, just look through the lens of salt intake instead. Okay, so if we look at this graph, this is time in days, all right? This is arterial pressure. This is sodium intake. So the point of this chart is to show you how arterial pressure changes as our salt intake increases. Okay, that's what we're, many of these graphs are designed to prove to you that what you're being taught is true. Okay, that's what they're for. It's not to confuse you, believe it or not. Okay, so if we increase our salt intake 580, 240, 500, okay, let's look at our normal control first. This is all of you right now. You'll see that your arterial pressure doesn't really change, even though your sodium intake changes dramatically. Why? Because of this, right? The more salt intake you have, the higher your fluid volume, the less active your RAAS system is, right? Converse, also true. If you cut your salt way down, cut your fluid way down, now your RAAS system is going to be more activated. It's going to bolster your blood pressure because it would have been high. All right, so let's look at the other curves here. If we have a patient on an ACE inhibitor, we see that instead of having a flat curve, at the low end, we have decreased blood pressure in response to decreased sodium. This is because we've knocked out the RAAS system, right? At least on the low end. So it means that in a patient who's on an ACE inhibitor, having a low salt diet adds to the effect of lowering the blood pressure. Now the red line there is what angiotensin II is up to. In other words, if we had angiotensin II around all the time, outside of the renin-angiotensin-aldosterone system, we're pushing angiotensin II. We see that our blood pressure dramatically increases as our salt content increases. And it's what we're seeing here is normally when your salt intake goes up, the renin-angiotensin-aldosterone system is turned down, right? In this case, it isn't, because we're giving the direct effect angiotensin II. So increases in salt cause an increase in blood pressure. Some folks have a more vigorous renin-angiotensin-aldosterone system than others. So for some folks, the reason they have high blood pressure is because their salt intake is too high, right? And even though their salt intake is too high, their RAAS is still on a little, right? So we end up with hypertension. So this is just proving that the renin-angiotensin-aldosterone system does its job. All right, you like that one? Isn't it lovely? Not really. And before you freak out about it, all it is showing you is when these different systems are playing a role in blood pressure management. Okay, so down on the x-axis is time, and this is, we'll call it change, right? Maximum feedback gain at optimal pressure. All that means is how much effect are these things having on blood pressure, right? So our baroreceptor line, you'll see, the baroreceptors, remember, are triggering the autonomic nervous system, okay? So they can make a change very quickly and can sustain that change for seconds and minutes, but not so much hours. See that? So that's nervous system control. Chemoreceptors kind of follow the same line. They're just a little bit of a weaker effect, right? So chemoreceptors, seconds, minutes, hours. On the hours to days side of this, now you're seeing your aldosterone line, you're seeing your renal blood pressure volume curve, right? Those are happening over hours to days. So that's all this is showing you, is that we have our nervous system effects in seconds, minutes, and hours, and we have our hormonal and kidney effects in hours to days. Okay? And see, that wasn't so bad. All right, let's roll. Okay, blood pressure doubles. What happens to urine output? Yeah, very good. It's going to go up dramatically. It won't exactly double, okay, but it will go up significantly. That's pressure diuresis. The upside is your plasma volume is going to go down as urine output goes up. As plasma volume goes down, your blood pressure goes down. So the original problem is resolved, right? That's what makes pressure diuresis such a beautiful thing. In reality, pressure diuresis is probably the single most important factor in keeping our blood pressure where it is. You know, that as pressure goes up, we tend to pee out extra fluid. All right, Mighty Ostrich, quick early lead. All right, blood is transfused into a dog with no sympathetic nervous system. Which of these is going to happen? I should have given you more time on this one, sorry. You're rushing at the end, but I don't know, just pick one. All right, so we're giving a blood transfusion to a dog with no sympathetic nervous system. The key with no sympathetic nervous system is it means there won't be any vasodilation, okay? There won't be any results of baroreceptor effect. So all we're going to see if I give extra volume to a mammal, well, I'm going to increase the blood pressure. When I increase the blood pressure, I'm going to increase the urine output. The urine output will stay increased until the pressure falls, right? And then when the pressure falls, urine output will go back down to normal. So that's pressure diuresis again. Let's not do that one on the exam, eh? Okay. The daring seal is up. An individual has a consistent blood pressure of 120/80. They start drinking more water. What happens? Yeah, see, this is one of those, we've been talking about it enough that you're like, well, the blood pressure will go up. Really? So when you finish all your water that I see around, your blood pressure is going to be high. No, it pretty much stays the same because we have intact sympathetic nervous systems, right? So we have a little vasodilation, a little decrease in TPR, our blood pressure stays the same. Okay, so remember, the long-term ramifications are not a big change. Okay. Dang, that was a big one. That one probably hurt a few people, though. All right, vascular resistance in the kidney increases. What will happen to urine output? Vascular resistance in the kidney increases. That's all right. No one will ever know after this. All right. Well, you got it down to it'll go up or down. That's good. All right. So vascular resistance in the kidney. Remember I said that was the special case. All right. Because if you're blocking pressure getting into the kidney, it means the kidney sees less pressure, right? So essentially, we've increased the resistance going in, so there's less blood and less pressure going into the kidney. That's going to reduce urine output. All right? Bit of an unfair question for where you're at right now because we haven't talked about how the kidney works yet, but we will in a matter of a week or two. All right, so our winners there, Expert Goat at the top. Ooh, very high score too. Barely missed any.